Thank you for the wonderful presentation. Next, I would call upon stage Dr. Raveen, final year postgraduate, to present his case of a 14-year male with splenomegaly along with Dr. Chandana, final year postgraduate in general medicine. And thank you, Dr. Krishnamurthy sir, head of the Department of General Surgery, for coming. He would be moderating the case. Thank you.
Thank you, ma'am. Good morning, everyone. My name is Dr. Raveen, General Medicine, final year PG. Hereby presenting a case about a 14-year-old boy who presented with a massive spleen. Coming to history, he's a 14-year-old who presented with pain of the wing, left-sided, for the past 15 to 20 days, along with a cold and cough for the past 10 days in August 2022. Later on elaborating on the pain of the wing, it is left-sided, around hypochondriac region. It was a drag and tie, intermittent. It was aggravating on intake of food, relieving on one episode of vomiting, presented with cold and cough also, which was mucus in consistency, non-bed strain. It was not associated with any fever, cold, with fever, loss of appetite, or any issue of any TB. So this is a timeline of events. He has an elaborate history, presenting from the past, like when he was an age of around 1 year. His parents noticed patient was having a delayed milestones, as well as patient was also having history of nausea, vomiting, as well as low stools. Low stools were on approximately 25 to 30 episodes, which were greenish in color, moderate consistency. Coming to vomiting, he was having 4 to 5 episodes of vomiting, which was non-bilious and non-projectile. At 9 years of age, he was complaining of neck swelling. He was diagnosed to be having hyperthyroidism. FNAC was done. It was showing hyperplastic goiter and was started on thyroxine supplementation. Later on, at the age of 12 years, he was diagnosed with having chicken pox, which was resolving on its own within 10 days. At 13 years of age, he presented to a hospital complaining of yellowish discoloration of eyes with even yellowish discoloration of urine. He was treated for jaundice outside, and later on he was referred to a hospital in view of not resolving jaundice. At 14 years of age, he presented twice again, complaining of the single complaints, pain of tummy, left-sided, predominantly, as well as cold and cough. So the initial problem on elaboration of these symptoms, his stool examination turned out to be infective origin. E. coli was isolated. And child responded well to the antibiotics as well as antifungals they were prescribed at that point of time. Stool consistency changed gradually to semi-solid, and it was later on gradually normal stool consistency was acquired around approximately 6 months. Coming to his childhood history, at 9 years of age, he was diagnosed to be having a neck swelling. Parents noticed patient is having neck swelling and also had difficulty of swallowing of food. He was brought to multiple hospitals and all. Later on, he was diagnosed to be having hyperthyroidism initially. FNAC was done, was showing hyperplastic goiter. USG neck was showing decreased enlargement of both lobes of thyroid glands. So the initial TSH was around 0.57, T3 was 217, T4 was 1.8, and he was started on propylthiouracil 50 mg once daily. As of October, they got the review back. The thyroid report was showing TSH of around more than 150. T3 of 12 and T4 was less than 0.3. He was later on changed to thyroxine supplementation of 25 mcg, and it was gradually, the dose was increased to 200 mcg over 6 months. At 13 years of age, he presented to the hospital with complaining of yellow discoloration of eyes, with 1 episode of bilious vomiting and yellowish discoloration of urine. These are his lab reports. There was a significant drop in hemoglobin for the past hemoglobin of 8.9 to 5.1. His LFT was showing raised bilirubin of both direct as well as indirect, with predominantly of indirect, with enzymes normal. Urine pigments, urine for bile salts and bile pigments were positive. HP electrophoresis was sent in view of patient might be having any HP defects and all. It was turned out to be normal. Anti-thyroglobulin antibodies was sent, was positive. It was positive. It was negative. Serology was negative for HIV, HPHG as well as HCV. and it is also negative for dengue, malaria as well as viral. This is a hemogram. This is a hemogram picture. HB is around 5.1, WBC was around 1700 cells, neutrophil is around 39%, ANC is absolute neutrophil count is around 663, eosinophil is around 80%, platelet count was around 1.5 lakhs. And also direct scopes was positive, another one was showing moderate splenomegaly. This is a peripheral smear showing normocytic anemia, normochromic and normocytic anemia with few microcells, teardrop cells as well as few pencil This is his family history showing he was a fourth child, grade 4 consanguineous marriage. He has two elder brothers, one elder sister. This is important because his elder sister, when she was 2 years of age, she had complaining of shortness of breath. Later on presented, whenever diagnosed to be having even splenomegaly. Bone marrow biopsy was also done.
Can you tell us what is grade 4 consanguineous marriage and kind of what is the prevalence of consanguinity here for our international audience?
Yes, sir. Usually in India, most probably people might go into like marrying the relatives and all, third degree relatives, second degree relatives. Leading this to having people might be having the genetic disorders. You can suspect in this part, as also was having suspecting of any stored disorders also.
What is grade 4 consanguinity, which you mentioned? Any grades of consanguinity? So when you say grade 4, what am I supposed to think of in terms of relation to whom he is married? Okay, that's complex. Okay, fine. Let's move.
And also she underwent bone marrow biopsy twice and was also advised for splenectomy. But parents have denied for splenectomy. As well as she was underwent multiple blood transfusions every 25 days. And also she used steroids for 1 year and ultimately she expired around at the age of 5. Based on this, we thought of provisional diagnosis of patient might be having a spectrum of autoimmune diseases, autoimmune thyroiditis. We also suspected patient might be having an autoimmune hemolytic anemia, a variant of common variable immunodeficiency syndrome, and also storage disorder of type 1 Gaucher's was considered. In order to rule out CVID, we have checked for electrophoresis, which has turned out to be normal. So he was started with methylprednisolone 32 mg based upon body weight for 5 days and was later converted to oral dosage. It was tapered to 2 months. And also oral therapy as well as B12 therapy was given based upon standard B12 regimen for 6 months. At 14 years of age, he presented with pain of tummy left-sided. Since again 5 months. His hemogram was showing 7.8 hemoglobin, TS was around 600 cells, platelets were around 20,000, showing pancytopenia picture. Ultrasound was done, showing portal vein dilation of 16 mm with massive splenomegaly with no ascites. Portal vein Doppler was done, it was showing portal vein of around 1.7 centimeters or 117 mm. Liver was normal in size and echo texture. Spleen size was 24 centimeters. Spleen vein was dilated. And it is also 17 mm and our artery was patent. There was no extrahepatic portal vein obstruction. Upper GI endoscopy was also done showing no esophageal varices. So ultimately we went for even CT angiogram. It was showing massive splenomegaly with dilated portal veins as well as splenic veins. This is the dilated portal vein. This is spleen, this is liver. You can see here this is a dilated portal vein entering into the portal hepatitis. So we thought a patient might be having a portal hypertension. So based upon this article, it is showing that patient presenting with chronic liver disease and all with portal hypertension, if it is more than 1 normal portal diameter is around 12 mm plus or minus 2. This person was having approximately 17 mm. It was correlating with portal hypertension. And this is also a study about patients presenting with Hashimoto's thyroiditis. There was a correlation towards presenting with idiopathic portal hypertension. They had, this is a case series of 3 people. Then it is showing a immunological role in pathogenesis of idiopathic portal hypertension. So based upon this, we come to a diagnosis of patient is having a pancytopenia with massive splenomegaly. We are suspecting the first differential was non-cirrhotic portal vein fibrosis, and this non-cirrhotic portal vein fibrosis might be because of autoimmune thyroiditis. And storage disorders were also considered, like type 1 Gaucher's. So we went for a bone marrow biopsy as the patient was having extensive generalized lymphadenopathy all over the body. We went for a bone marrow biopsy as well as a lymph node biopsy, which turned out to be on the reactive hyperplasia. There was no evidence of any inferiority origin or any malignancy like Hodgkin's. So we sent our slides to a pathology people. They are diagnosed the patient might be having an oocyte offline. Ultimately, we went ahead with decision of splenectomy as the patient was symptomatic with irritation of pain abdomen, also having vomiting after intake of food with worsening of pancytopenia. So we also went ahead with on-table liver biopsy to exclusively rule out NCPF, which is the normal. In NCPF usually the liver is normal, but only the portal vein fibrosis is severe. This is the gross specimen of spleen, which was weighing approximately 1.4 kgs. So biopsy was done. So we have sent a part of the liver biopsy to an outside lab. The picture was consistent with non-cirrhotic portal vein fibrosis. And liver and spleen in our hospital, in our lab, it was showing a possibility of storage disorders. And incident input which was done on the OT day, it was showing reactive. This is my follow-up. Patient is presented after splenectomy was done on POD1. The pancytopenia has completely recovered. And this is 1 month follow-up. Patient is having hemoglobin of 13.9, TS of 10,600, and fetches around 2.6 lakhs per cubic mm. I would like to call upon Dr. Supraja to here present about the OD findings. Thank you.
Good morning, everyone. Dr. Supraja, final year postgraduate from Department of General Surgery. So this particular case, we were called by the Department of General Medicine to review a case of a 14-year-old male and the history and all the investigations and the findings as explained by my colleague, Dr. Raveen. So splenectomy was indicated in this patient. Our considerations being one that he's having an hypersplenism and also the massive splenomegaly. It is almost crossing up to the level of umbilicus. In such cases, and the patient also is having recurrent episodes of pain abdomen. One being with such massive splenomegaly, even a trivial trauma could have caused a splenic rupture, and a splenectomy will benefit him by reversing all the pancytopenic condition. We have opted for an elective open splenectomy. Open the indication because of again the massive splenomegaly, and before preoperatively as prophylaxis, he was given vaccines which were done outside only. He received vaccines for pneumococcus and meningococcus, and we under general anesthesia, a decision to perform an open elective splenectomy was done. A midline incision was taken. This is the image preoperatively after painting the part. So this is the enlarged spleen. I hope the picture is clear. This is the enlarged spleen, and we have opted to go with a midline incision, and after opening it, so it was enlarged. That usually the challenges surgically we get to see in such massive spleens is that the ligaments will be expanded and stretched out ligaments, and a blunt dissection is always preferred in order to avoid any kind of vascular injury. And given that this is a long-standing condition, we expect some adhesions between the spleen and the colon, the splenic flexure of the colon, and the fundus of the stomach, and we've carefully dissected them, and this is the gastrosplenic ligament which can be seen with the vessels. Actually, this was taken a snapshot from the video that we had, sir. So we've carefully ligated these vessels. So the leno-renal ligament, the gastrosplenic ligament, they've been carefully divided, and the vessels were ligated. Here in this image, okay, I just have one. So here, this is the spleen, which actually, as we opened, we could actually the massive spleen was evident. We from the lateral surface of it, we delivered it into the wound, and it was this part of it was looking something like an accessory spleen, which was only that the such massive spleen just folded on itself, and the inferior pole. This is the part of the spleen that was folded upon itself, and once we have ligated the vessels, we could clearly visualize the color change. So this is the splenic vein. As with correlation, the findings were on par with the imaging, where we can see a splenic vein which is having increased diameter of about, we didn't measure it, but it was given 16 mm on the CT, and which was correlating with that. And so this is the vessel that the splenic vessels which were like after dividing the gastrosplenic ligament, these vessels were doubly ligated. We did 2 ligations proximally and 1 distally towards the specimen. And this is the discoloration that is evident once the vessels were ligated, both the artery and the vein. And this is an image showing the delivery of the spleen after all the ligaments and the vessels are divided, dissected and ligated. So this is the specimen, the excised specimen, which was weighing about 1.4 kilograms. And post-operatively, the patient, he did well, like he didn't have any complications related to the surgery, and we started him on, we was kept NVM for a day, POD1, and then he slowly was started on liquid diet followed by soft diet. And he didn't have any other complications of fever or wound infection. His wound healed well after the suture removal was done on POD10. And the pancytopenic picture was reversed as was shown in the sequence of the panel of investigations as shown in the previous slides. At the minute, we had just consulted him. He had come to a RUPD last week where the wound is completely healed and he has got no other complaints of pain abdomen or any fever episodes. And his lung status was something of concern for us because after the general anesthesia, though he was extubated on the table, but post-operatively for about 5 days period, we had low degree saturations and the lungs were showing some opacities, which were eventually, he was kept on immunizations and the other antibiotic supports and that improved. So that's the problem. And also intraoperatively, I don't have the picture, there were mesenteric lymphadenopathy was there. So for the already preoperatively when we had done the inguinal lymph node biopsy, which was shown to have the Rosai-Hoffman's disease, we went ahead and performed a mesenteric lymph node dissection also. We took a couple of lymph nodes which was sent for biopsy. And also on request we have done the liver biopsy. Part of it, about half centimeter of liver section was done and which was sent for biopsy, which was showed as non-cirrhotic fibrosis, and also one more report showing the storage disorders. And the lymph nodes, mesenteric lymph nodes, were showing something like a reactive lymphadenitis, which was again something, inguinal lymph node and the mesenteric lymph node were having little different features, one being Rosai-Hoffman, the other is also reactive. Then post-op, also because the preoperatively the vaccination was already done, so usually when we do the emergency screen, we usually do it post-operatively, the vaccinations, and here in this case they were done preoperatively only, and then post-op there was no other events which were there.
Thank you.
Can I say something, Dr. Bishwas?
Yeah. Yes, sir.
Yeah. Firstly, I congratulate Dr. Bishwas and his team for selecting the topic as the complexities,
Optimizing
the clinical complexities. So, in fact, this was one such case which we have come across. This is as already said, 14-year-old boy. So he was referred to us with massive splenomegaly and with generalized lymphadenopathy, and with another sibling dying because of massive splenomegaly. So we initially thought of, since generalized lymphadenopathy is there in splenomegaly, so let us rule out lymphoma.
So for Akim who's listening in, Professor Krishnamurthy is the chief of surgery here, and it was his operating team where Dr. Supraja was also operating, and he was the one who was supervising the entire procedure. Yes.
Since he had generalized lymphadenopathy as well as massive splenomegaly without evidence of portal hypertension, even though the diameter is more, So we attributed that increase in diameter because of the massive splenomegaly over a period of time. The blood supply to spleen is increasing, and the venous return from the venous return from the is more. So the diameters were more. So and there were no esophageal varices. So we were very sure it is not. We are not dealing with a case of portal hypertension. Then one lymph node biopsy done outside, it showed as reactive lymphadenopathy. Then patient also had inguinal lymphadenopathy. Even though inguinal lymph node biopsy generally is not very diagnostic, but in this particular case, we had suspicious looking 3 centimeters size lymph node. So we went and did lymph node biopsy, which showed Rosae-Dorfman disease. They confirmed, and they attributed all the other lymph nodes which are there, probably in the mediastinum, cervical lesion, and the mesenteric lymph nodes, all attributed by pathologists as probably it is the Rosae-Dorfman disease. But nowhere we tried to check up the presentation of Rosae-Dorfman disease, whether the spleen can become such massive size. But we didn't get any supportive evidence. And subsequently, the histopathology of the spleen, it showed here as Gaucher's disease, that is a storage disorder. And then we took a biopsy also from the liver, and probably here I think pathologist might be true. It was not conclusive, but now I see that report outside. It has shown as the non-cirrhotic, non-fibrotic cirrhosis. So I do not know, this requires to be again the review, because and once we have seen the case, what we decided was patient is having definitely because of splenomegaly hypersplenism. The definition of hypersplenism is he has got pancytopenia and bone marrow was normal, and to the last point in the hypersplenism is once we do splenectomy, the counts will become normal. So it has fitted nicely into the hypersplenism. We did splenectomy, and subsequently all the parameters of blood like total count, RBC, platelets, everything has come normal. So now actually one is the histopathological diagnosis, Rosae-Dorfman disease and Gaucher's disease. So we think it is actually both diseases are in this, and he is mainly symptomatic because of hypersplenism, and he is relieved of his symptoms, and now presently he is doing very well. I think it has given us a lot, because this boy went to the various corporate hospitals in Hyderabad, like Krishna Institute, and he was investigated at various places, and they could not come to a conclusion. Even we also come to a final conclusion once we did the lymph node biopsy from the inguinal lesion and after splenectomy only. Otherwise, everybody was keeping in mind it may generalized lymphadenopathy is splenomegaly. It may be a lymphoma because other sibling died of splenomegaly. So, but that has been proved to be wrong.
Yeah, and but do we really have the final conclusion as far as the disease is concerned, particularly the pathology?
Pathology, the pathologists will be able to answer. Since the storage disorders can run in families, that's what the HOD pathologist says. So the Gaucher's disease is beyond doubt, and the massive splenomegaly is known to that.
No,
and
because we seem to be having two divergent views from two different pathologists. One is saying that the same thing is non-cirrhotic portal fibrosis. Our pathologist is saying that it is Gaucher's. And it's only based on the liver. I don't think they have commented on the spleen as storage. They have said liver is storage. And so this is something which we are. It's a complex disease.
Complex. One thing.
And plus, what happened to the Rosae-Dorfman, which was earlier there? I mean, currently there's no talk of the Roside Hoffman, and Roside Hoffman generally would not have so many other things. I mean, we always tend to think of there is one pathology to explain everything. So that is that thing where we are not able to.
I personally feel it is not fitting into critically.
WebEx Assistant is enabled to save audio highlights.
Is not fitting into cirrhosis, non-fibrotic cirrhosis of liver, because there was no esophageal varices. The back pressure should start in all the vessels, which go through the liver, but it hasn't happened so. It's the only splenic artery and vein are dilated, so it is fitting very well into the massive splenomegaly, and the cause for massive splenomegaly to me appears to be, if not Roside-Hoffman, appears to be a storage disorder.
Yeah, I mean, this is a very interesting point which we have dealt with before, that the portal pressure dynamics, it's a very peculiar physics that sometimes it all just goes into the spleen. You know, the flow is such that it's just going to the spleen, and the spleen is getting ballooned up. But at the same time, the varices are not getting the same amount of pressure. So we see in other occasions also we've seen that the varices are not present, but the spleen is ballooned up in a massive way. And this hypersplenism is a very, very classical feature of portal hypertension, and that's one of the reasons we thought of portal hypertension. And when we looked at the vein, the splenic vein diameter and the portal vein diameter, which was more than 16 millimeters, and which is very specific for portal hypertension. So it is currently still a complex thing as to why some patients develop the portal pressure in such a way that it is redirected to certain areas and not to the usual areas of textbook, as Akim said, the known domains that we are used to think about. So that's one point. And of course, the other most important point is the pathological conclusion, which I think we are currently still debating.
Probably the portal hypertension secondary to portal vein thrombosis. When it is only left-sided portal hypertension, that is the time where the esophageal varices may not be there, because
that is explained in a mechanistic way that when you are on the left side, the left esophageal parapet vein, they will not receive the blood. That is the reason you will not have
the
that.
same thing excludes now, because of if the liver problem is there, it has to, such as huge splenic vein and
a portal vein, a huge portal vein, and that is because of the obstruction to the portal vein, which is happening at a tertiary venous level. So that is NCTA. Like, it is not at the portal periportal area, it is at the secondary tertiary level of the branching of the portal vein where there is fibrosis. And that is the reason there is high pressure in that. And as you rightly said, anatomically, structurally, it should be expected in a blocked left paracel vein. But this is physics. I mean, sometimes the flow dynamics is such that it is inexplicable. So that's an interesting point actually, which is not very well often highlighted. So I thought I would even highlight this point. So shall we move to the pathologist? Yeah. So Akim, do you have any comments on the disease complexity that we have witnessed till now? And of course, we have not even touched on the person this 14-year-old boy is. Raveen hasn't talked about it. Dr. Rajkumar, did you meet this person as a person? He's a 14-year-old boy. I think Raveen and Chandana, at some point, I'm sure Dr. Rajkumar met him. But he's met so many of our patients. I mean, for him it will be difficult to keep track. Maybe if you see him again, you will. Yeah, Akim, any pointers or anything? Or you would.
Well, it's a classical example when thinking slow becomes really important. And this I would put into the atypical case category. This is very unusual. And I guess that the one thing that might be a post hoc interesting exercise is trying to draw a system diagram about the different aspects at the different levels of scale. What happens at the patient level, what happens at the bodily level, what happens at the spleen level, at the cellular level. to figure out how things hang together. This obviously is the outcome of many different interactions. He has several clinical issues that contribute to his presentation. So I think that it would be a good learning exercise.
Yeah, I think it's a very good idea for a system diagram, and maybe we could publish this in JECP. And I'm hoping some of our postgraduates here, Dr. Chandana, Dr. Raveen, Dr. Supriya, our intern who presented the biopsychosocial model, and I think we need her help and Dr. Rajkumar's help to create that other part of the scale, that domain. And Dr. Chandana and Dr. Raveen and Dr. Supriya, they are well versed in the known domains. So, and of course, our pathologist who is waiting for us us to let her present the pathology. So, yeah, I think we'll go over to the pathologist, Dr. Hafsa.
Good morning everyone, I'm Dr. Hafsa from Department of Pathology, third year postgraduate. On cytopathology of cervical lymph node, we have seen large histiocytes, plasma cells and reactive lymphocytes. These histiocytes, they showed abundant pale cytoplasm, centrally placed nuclei with prominent nucleoli. There were few enlarged nuclear enlargement and pleomorphism. Histiocytes, they showed phagocytosed lymphocytes, plasma cells, which is known as emperipolysis. This emperipolysis is a characteristic feature of Rosai-Dorfman disease.
Can you show us that?
These are histiocytes and these are lymphocytes. This is also a histiocyte and this is emperipolysis. It is a histiocyte with engulfed lymphocytes and plasma cell. These are lymphocytes. Even here, there is a histiocyte with engulfed plasma cells and lymphocytes.
Is there an etymologic breakup of this term, emperipoliosis? Does it actually mean from the Greek or Latin that somebody is eating up? Or possibly?
These features were suggestive of Rosai-Dorfman syndrome. On inguinal lymph node, study for histopathology, we have seen variable sized lymphoid follicles with sinusoidal dilatation which contain histiocytes. This majority of histiocytes showed phagocytosed lymphocytes, which is known as emperipolysis. These are variable sized lymphoid follicles with dilated sinusoids and multiple histiocytes. These are histiocytes. This is histiocyte which is engulfing lymphocytes. Spleen examination on gross after cut section, we have seen multiple small nodules less than 3 mm size. By seeing gross, we had 2 DDs, amyloidosis and storage disorder. On histopathological examination, we have seen follicles of variable size with large cells showing foamy and vacuolated cytoplasm and central nuclei. This is low power, this is high power view showing large cells with foamy and vacuolated cytoplasm and central nuclei. Differential diagnosis was amyloidosis, so we have done congruent stain. Congruent stain has to, when it is positive, it has to show apple green birefringent, but we have, in our institution, it turned out to be negative. On liver pathology, this is a vein, central vein, with duct proliferation. These are normal hepatocytes. These are bubbly hepatocytes with foamy and vacuolated cytoplasm and central nucleus. On mesenteric lymph node, variable size lymphoid follicles with prominent germinal center. This turned out to be reactive hyperplasia of lymph node. Possibility of storage disorder, a type 1 lysosomal storage disorder can be glycogen Torcher's disease or Niemann-Pick disease. By doing PAS stain will be positive for glycogen storage disorders and negative or weakly positive for lysosomal storage disorders. In our institution, it turned out to be weakly positive. PAS stain.
A round of applause for Dr. Hafsa. So, Yeah, and I think you have. There was one thing about why we had two very different diagnoses from two different places. So one possibility was that the sample which was sectioned and seen by the other pathologists could be different.
Different area.
It hit an area where the NCBA was located, whereas you got the piece with multiple sections also. You could not get that tertiary radical which was showing a fibrotic area. So yeah, I think that is one possibility. So with that, I think we'll go on to the discussion of this case, the formal discussion which has been prepared by Dr. Chandana. So what